Thank you. It's a pleasure to be here today virtually and to join in a conversation with you. Uh, as you were walking in, I saw some familiar faces, and it's wonderful to see both new and old friends. I'm sorry that I can't be there with you in person, and hope that at the next meeting I can be there in person. S- so let me share my screen here. Hold on. So I was asked to speak about some of the United States experience with medical school engagement during the COVID-19 pandemic. And I wanted to step back and talk a little bit about where medical education was as well, and then our responses to the pandemic, and then how students became engaged with the communities and our lessons learned related to that also. So I know many of you are familiar with the Association of American Medical Colleges, or AAMC, but just for those of you who are not, we are a member institution, including 172 of the accredited schools of US and in the, multiple Canadian medical schools, many of the major teaching hospitals within the United States, and many academic and professional societies. So I wanted to step back and give you a little bit of the summary of where medical care is changing in the US, because it lays an important foundation for what we are thinking about both clinical care and about education. And it impacted the way that we responded to the pandemic. So, one of the important areas, and I know we've talked about this before, as we've talked about the importance of primary care with this organization, is that so much more care is moving from the hospital to the ambulatory or outpatient setting, and even into our communities and thinking about public health. And as we all know, even without the pandemic, the complexity of care that we are delivering and that our students need to learn is increasing as well, with our population becoming older, more diverse, and having more multiple illnesses. And as we understand science and think about what our students need to know as our understandings of pathogenesis and diagnostics increases. And again, all of these, the pandemic shone a spotlight on those as we think about the rapid advances that we had with COVID and what we both learned and then needed to teach both our students and health professionals about. And importantly, thinking about the role of the patient in their own care, and the role of technology was something that we were working on. And as you all know, with the pandemic, it accelerated our pickup of both telemedicine and actually telelearning. So as we think about the role that the students took, it was important to step back and think about the fundamental principles of professionalism. And this is the physician charter that still rings true, although it really came about in 2000. And the first is really the primacy of patient welfare, and the idea of altruism, or putting the patient interest first. A second is patient autonomy, and the patient's right to make their own decision and be involved in their decision making. And the third was social justice and the idea of access to care. And this was an area that, as I reflect back on my experiences in medicine and medical education, received relatively less attention than the first two, as we thought about what the fundamental ideas of professionalism were. And then the other thing to think about, which again was our baseline, and then how did it change with the pandemic, is that when we think about clinical learners in the clinical setting, what were the things that we needed to consider? And first and foremost, as we think about allowing students to interact with any patient at any level, has always been patient care in society. And that was the thing that got the most discussion and the most attention as we devised our learning and as we taught our students how to think about professionalism. Certainly for all caregivers and all of the people involved in medical education, being sure that student safety was appropriate and student learning was important, although patient care and patient safety always has to come first. The bottom, public safety and population safety, up until the pandemic, was certainly part of professionalism, but it was something in the day-to-day life of medical educators in the US we didn't pay a lot of attention to. It hadn't taken precedent, and it was really thinking about the student's interaction with the individual patient. The pandemic changed all that, particularly in the US, as the first surge hit. We had too little or no protective personal equipment, or PPE, had no testing, and recognized that it was actually a public safety issue, a population safety issue, for students to be involved in the clinical care setting. So before we go into that, I wanted to share a little bit some of the reflection that we did at the AMC as we were trying to lead our communities and work with our schools in thinking about how do we make decisions about what to do with learners, where they should be taught, what we should do with even our staff. And really thought about a number of different areas for making rapid, critical decisions in times of uncertainty. And one of the first things that we needed to do was really think about what is our role as an organization? What is our decision-making role here? What role do we take versus what role is for schools versus what role is for communities? And really importantly, and we did this over and over again, identify the data gaps, knowing that we couldn't fill those gaps in the time we needed to make the decision, but to know what the gaps were helped us to be more certain of the decision that we were making, to know what we didn't know. And then importantly, always to identify what are the ethical potential conflicts and what are the value conflicts, so that we could be very aware of what it was that we were weighing, because we were weighing, don't have the information, and there are potential conflicts. And an easy one would be students need to learn, but we need to protect the public health. We needed to really lay both of those out and put them side by side and say, so how do we balance this? And then importantly, as we identified those things and moved into the decision, always went back to core things. When data was available, use the data. And be really clear on both our mission and our values, and weigh any decision that we made against those. And then revisit that, because it was such a rapidly moving space, that what was the right thing to do in March of 2020, the data had changed, the pandemic had changed, so that by summer of 2020, we were rethinking what we were doing as well. And then really importantly is we had to develop a new team, and we had multiple teams within the AMC for different areas to really be able to make rapid decisions internally, using the data, grappling with the conflicts, and very importantly, be able to reach outside to our members, our medical school leaders, our educators, for a trusted resource for review. So most of the work we did internally, but again, the idea of having a core set of people that were on the ground, that were living the work, that we could say, does this make sense to you? What are we missing? Or to say, we made a recommendation in March, it's now June, does this still make sense, or what are we missing? So this framework really served us well, and I think we learned something from stepping back and thinking about, well, what do you do when you need to be making decisions and you don't have all the data? So I wanted to talk first about the decision that we made, and I think many of you did as well, back in March of 2020, in that we recommended that students who were doing their clinical rotations be removed from direct in-person patient contact. And again, this was in recognition that at that time, the pandemic was in very high levels in parts of our country. surging astronomically high, although very small in other parts of the country. And that we didn't have sufficient personal protective equipment. And you'll remember there was no testing available at all. And so we recognized that this was when the entire country was going into lockdown, except for essential workers, to really minimize the number of people in the entire country interacting with each other, to flatten the curve so we didn't overwhelm our hospitals. And so recognize that the public health crisis, the need to totally limit the number of people, exceeded in the short run the need for our students to continue their clinical experiences. So we recommended that they all be removed from the clinical experience. And the vast majority of the schools went along with the recommendation. It was a recommendation. We couldn't enforce it. And they quickly pivoted and developed online learning and other opportunities for the students to learn independently. And to think about other ways that they could continue to work on their education, but not with direct patient care. I could talk more about the education side of things, but actually I'm going to talk about the other half of what happened, which was then the students' involvement, voluntary involvement in community outreach kinds of activities. So on the curriculum side, we enabled our schools to, as they were developing new courses, new ways of doing things virtually, new modules, to share them with us. We cataloged them and then they shared them back with each other and had thousands of people, thousands of downloads. So schools were using each other's newly created curricula to really continue the students' learning. At the same time, the students had a huge appetite to contribute. They are healthcare professional students. This was a healthcare crisis. They were part of their community. They wanted to be part of things, even though they couldn't be actively involved with the healthcare team. And so they began to devise their own experiences and reach out to the community, and the communities reached out to them. And we recognize both the importance of this and the importance of facilitating sharing of this. So just as we had done for the curriculum, AMC supported our medical schools sharing across the work that their students had done and were volunteering to do, how they did it, how they set it up, what rules they created, so that then again, one school could learn from another school. As you can see from this list, the number of types of projects was vast. Some were very involved in healthcare. The telemedicine support in particular, sometimes that was volunteer, sometimes it was actually curricular, so that students would, at some schools, became the frontline for doing wellness checks. You'll recall that people, before we had testing available and any vaccines, that many, many healthcare workers were sent home and were quarantined. And so at some of our schools, the students would call for wellness checks, make sure that that individual was still okay, didn't need to come in to the hospital to get their oxygen levels checked, et cetera. They also did support of the healthcare workers through childcare for the healthcare workers, through collecting personal protective equipment, and a whole range of things. And they also did a lot that was just reach out to the community in general. So working with the departments of health in staffing and answering questions, because the public health offices were overwhelmed with phone calls. So they just were able to answer medical questions. They did calls on COVID screening and triage again for hospitals because they had the expertise to do that. And then they also did just food banks and hygiene kits and reach out to the elderly who were isolated. And many students said that this is a way for them to feel a part of the solution, even as they were not able to do their regular learning. I wanted to spend a little bit of time on the last bullet there, the COVID-19 vaccine effort. And before that, so here's just, one example, which came from, one of our schools, which was to, again, identify risk and educate patients, did mental wellness check-ins, and again, helped with food insecurity. So really across a whole range of areas. We have in many of our schools student-run free clinics. Most of those, and those are for the medically underserved and very vulnerable population. The vast majority of those were paused initially in the pandemic. And so this was a way to continue to use that concept without delivering care, but to connect with those patients. And then another example, again, specifically from University of Kansas, this was students at all levels, so first through fourth year levels. And importantly, it was interprofessional. So it was both medical students, pharmacy students, and some other health profession students that basically ran the call line for an underserved county in Kansas, answering questions, triaging if people needed to come into the hospital, and importantly, providing just general education and information, because as we all know, that was a huge, huge need early in the pandemic. And then I wanted to talk, because across the country, when vaccines became available, the question was, how do we get them into the arms of everybody? And some of it was just need for brute force numbers. So many of our schools with their students ramped up COVID-19, massive organizations. And as you can see, these are just quotes from 3 different individuals from 3 different schools that inside a week and a half, we had 400 plus volunteers. That's from Indiana, the Midwest of the country. Paul Wallach is the head of the education program there. And then for Kelsey Wood, a 4th year student, really her expression that she was grateful to be able to be a part of this. And then again, a 4th year student in New York City, Amanda, really teared up thinking about the opportunity to participate in this. So again, it was a need, but it was also for the individuals who participated, really met a need for them to be a part of the solution. I think really importantly, as we think about this community connection through COVID-19, it was a combination, and the ones that were most successful were school supported and student driven. So the students had the ideas and the students were empowered to do it, but the school supported it, and they supported it in a couple of different ways. One was resources. Another was really just providing some of the organizational capabilities for that. But another part that was important and that we need to not ignore as things move forward was giving students guidelines about what to do and how to be safe about it as well. Because even though this was voluntary, they needed to make sure that the students were being careful about their own safety. And there was pressure actually for students to do, in some states where there are high levels, to join volunteers that were run by the state that may have exceeded their abilities and really what they were able, what their skill levels were at that point. And so schools really helped students to say, this is the framework in which you should be thinking. These are the kinds of things that it's appropriate to volunteer for. And those that were really run through the schools had the best certainty that the students were doing things that they were both able to do, that were important for the community, and that the students were safe doing as well. But again, the creativity the students brought, so really the combination, school support, but student driven, were the most successful experiences. And what we learned from this is that it had a huge positive impact on the students. Our students have always been involved in volunteer activities within the community, but the degree to which the students got involved and the degree to which the students were leading and creating this was more than before. And it led to student professional development, student feeling belonging to the community, even though they were at home and relatively isolated. And it led to overall great outcomes for the medical school in creating a greater sense of connection between the medical school and the community that it was serving, even more than had been done before when there had been student volunteer activities. And the other piece of this is that many times the students came up with the ideas because they were talking to people within the community. So it's also community driven. So when I was finalizing this talk just a few weeks ago, I thought I would be saying, so now that we are, I hoped I would be saying, so now that we are nearing the end of this pandemic, and I think I need to say, so now that we are moving into the endemic phase of this pandemic, I think the real question is this, which is, what have we learned? What now? And as we become either post-COVID or post-pandemic, what do we need to continue? What do we need to learn from this, particularly related to student involvement in the community? Because they had been being involved. And I'm going to step back here. And this was one of the critical points, which is that our learners are essential members of the healthcare team, and that they are essential members of the community care team. And I want to spend a minute on this idea of them being an essential member of the healthcare team, because as you'll recall, we recommended that students be pulled from clinical rotations in March. And then as PPE, protective personal equipment, became available, and as testing became available, and it became clear the pandemic was going to go on for a long time, it became appropriate for students to go back to clinical rotations. And some hospitals and clinics were reluctant to bring students back. It would complicate things again. It would potentially take their testing and personal protective equipment resources. And so AMC made another statement, which is, while it's true that at any given moment, no single student is an essential member of the team. They take 2 weeks of winter break. They can take 2 weeks in the summer, and the healthcare team continues. However, as a group, our learners need to continue to progress on time, or we will have a healthcare shortage. If our learners had not been able to graduate in May of 21, and if they weren't graduating in May of 22, we would not have interns to continue the work. So the idea that as a group, the healthcare professionals, and this is all learners, are essential members and their education is essential to healthcare was a critical point to make that had never been questioned before. But again, it was important. And then importantly, that their ability to connect with the community, particularly in times of crisis, and to expand the ways that an academic health center can support its community was really critical. And then this is taking a big step back, and it's not just about community engagement, but I wanted to share some of the high level things that as we in the US, in both the medical education and then the medical school student community connection, these are some of the biggest takeaways for us as we move forward, which is number one, that we really need to make the learning environment truly inclusive. And then importantly, we saw over and over again that when learners, the students, are involved in their own creation of their learning experiences, that it's more successful. When the schools had to stop traditional clinical rotations, the more they involve students in thinking, what can you do and what will work, the better ideas that came out and the more successful it was. So really bringing the student voice in always and more to every decision related to them is something that's really important. As you know, we have had in the US, as well as the COVID pandemic, really shining a spotlight on the racial epidemic here as well. And so it has reinforced the need to build equitable learning environments for all of our health professional learners. And really importantly, in the third bullet, thinking about this concept of professional identity formation and personal well-being and how connection with the community can help with that as well. And then importantly, again, back to this second epidemic in the US, is we are focusing on our anti-racist, anti-discriminatory curricula and practices really in all areas of healthcare, and particularly for medical student education. It's a long process, but it's something that we're very active in. And then again, in the education side, just wanted to highlight that the pandemic highlighted two things for us across the continuum. And that is that interprofessional practice, interprofessional care, and therefore interprofessional education is absolutely critical to healthcare and absolutely critical in times of crisis. When we had the biggest surges in New York and then on the West Coast, and that truly hospitals were overwhelmed and healthcare workers were overwhelmed, that those areas where they sometimes redeployed people, they brought pediatrician residents to take care of non-COVID adult patients. They brought physicians who hadn't been in the hospital inpatient setting for a decade to supervise there from their outpatient setting. That those teams that were most effective were those that were interprofessional, and that everyone was able to learn from each other and really work at the top of their skill list. And the idea of competency-based education. So if I'm put into a new setting suddenly, what do I need to know to be both confident and competent? Really highlighted, again, those that had a competency framework for thinking about that, and assessments were the ones that their caregivers and learners were most confident in the work that they were doing as well. So these are two areas that we recognize we've been working on, but that the pandemic highlighted that we need to do even more with that. So I am going to stop there, stop sharing my screen, and I'm happy to take questions.
My concern is that we have a group of students that they voluntarily return to the clinical practice. But there is a group of students that they decide to stay at home. They don't feel safe. Then what compensation, what remediation you did to compensate the group that didn't come back in the same manner that the first group did? That's the first question. Do you hear me?
Yeah. So when the schools decided that it was safe for to return, and again, going back to that decision making, the balance of the need for students to come back and see inpatient, real patients, balanced against the ongoing potential risk, was enough that they said it is time for students to come back. If a student had a medical accommodation, it was treated in the same way as other medical accommodations, which is not very often, and it was very limited. But otherwise, if a student did not have a medical accommodation, they were told, talk to your student affairs people, maybe talk to a counselor, but you need to come back. This is, or you are not enrolled in medical school. They were given some time, but when it was time to come back, unless they had a medical reason, they had to come back. Most students were happy to come back. Some needed significant conversation, individual. And again, the schools that had the most satisfaction with students had ongoing conversation to make sure that they were as informed about the risks as everyone else, because they didn't know either. So again, what are the facts? What do we need to know? This is why you need to do it. And they did say there has always been some risk for health professionals in caring for patients. We cared for HIV patients. We care for influenza patients. We care for tuberculosis patients. We try to protect our students. The more the risk, the careful we are about bringing students in. But the sense was, with personal protective equipment and testing and what we knew about the COVID, that the risk that the benefits outweighed the risk. So through conversation, most students did that, and they gave time, but then said, "This is what you must do." The other thing we ran into, which you didn't ask, or maybe you did, is with vaccines. Our hospitals had developed a vaccine mandate. Anyone in the hospital had to get vaccinated. That included health profession students. It was the same. The vast majority were like, sign me up now. Yes, yes, yes. Some had hesitancy, and talking with them made the difference. And there were a very, very small number who the dean said, if you do not get the vaccine, you will no longer be a student here. And tiny number in the entire US did not. But some took that point of it's this or that to do that.
Thank you. But my other question was, there are 2 years from the beginning of the pandemic. Then probably you have a lot of data. And my question is if will the AMC have any information or if it's working to identify in the regular curriculum what group of subjects need to be eliminated and what group of subjects need to be added, like telemedicine, like vaccination, like public health, that are not in the curriculum actually.
Yes.
Thank you.
Yes. Excellent questions. I would love to hear what you all are thinking. What we found is that schools rapidly put in a small amount of curriculum about COVID, and it evolved as COVID evolved. And that's number one. Number two, we had known this before, but the pandemic accentuated that although physicians are not public health providers, we do need to increase public health education and telemedicine education as well. AMC has developed a set of core competencies around telemedicine, which is for both students and residents, recognizing that telemedicine is going to be a bigger part of what we are doing. I will say what comes out of the curriculum is more of a struggle.